Thank you, sir. Hope I'm audible.
Okay, yes.
I'll proceed. Good evening, ladies and gentlemen. Thank you for giving me a wonderful opportunity to present this study. It's about a toe deformities and diabetic foot from a different perspective. For the people who are not aware, we are laying down the first principle and practice of diabetic foot in Indian literature over the last 100 years, which none of the specialties have. And we are working on last 11 decades, and we have just completed in 2020. And this is the whole concept of the modern diabetic foot surgery, which is from India for the first time. And this paper is a continuation of this innovative work which we are doing it, as is the first such known principle in Indian literature. We are aware that diabetic foot ulcers are caused due to multiple factors, and they include neuropathy, ischemia, foot deformities, trauma, and previous ulceration. If you look at foot deformities, often various deformities exist in forefoot, midfoot, and hindfoot, consisting of hammer toes, claw toes, mallet toes, hallux valgus, Charcot foot. Today, everybody is talking about Charcot foot and giving much importance to it. It's actually uncommon, though we are seeing increased cases, and it's often difficult to treat. Toe deformities are often underestimated in diabetic foot, but they are highly common in clinical practice, and we need to look at it as they are one of the pre-ulcerative causative factors that can lead to amputation. We decided to relook into toe deformities in a different concept in diabetic foot and start perceiving from a new angle. And that's why the first laid universal classification of diabetic foot from India for an ulcer called SCC classification was applied to this, just the way TNM system is applied to breast, stomach, thyroid. Simple concept. The toe deformities were divided into three simple types, like how diabetes is divided, and we said that type 1, 2, and 3, which are simple, complex, and complicated. If there is only a deformity without an ulcer, it's a type 1. If there is an ulcer or callus in that deformity, it's type 2. And if there is any form of infection in form of an abscess, osteomyelitis, cellulitis, the toe deformity becomes type 3. We gave a simple algorithm that for type 1 toe deformities, please do not operate on diabetic foot. Use splints, toe caps, and diabetic footwears. And if you have a complex deformity of the toe where there is an ulcer, in such cases, do cleaning and dressing, corrective surgeries like tenotomy, arthroplasty, offloading, and footwear. And we made our protocol very clear that only type 2 or the type 3 needs to be operated and not the type 1. The type 3 consists of any form of infection where you need to do debridement, resection of infected bone, followed by antibiotics. Classical example of a hammer toe, which is a type 1 deformity without an ulcer here. Mallet toe also is a type 1 deformity, and the claw toes, which we have commonly seen, are type 1 deformities. When there is no ulcer, we advise not to operate on them. The aim of our study was to analyze these visible named toe deformities, which are structural, seen in diabetic foot through the new extended SCC classification for diabetic foot. This study was done at our institute, which is in Arion Hospital, and it was a 1-year study duration, and we had obtained an IC approval for this study. We included all the visible named toe deformities, the structural, invisible, or the one does not have named were excluded in this study by us. And also the patient who had functional toe deformities or operated by other surgeons were not included. Congenital toe deformities in diabetic foot patients also were excluded in this study. Data analysis was done using software SPSS 22, and we had applied the chi-score and Fisher exact test to have a study parameters on category K between the two groups, and p-value of less than 0.5 was considered significant. We had included a total of 27 new patients who had come to us during this study period. An average age of most of these people was 61.85. Male dominated, where 60% of them were males in this study. 48, approximately half of these patients had a diabetes of more than 12 years duration in this study, and all these 27 patients had peripheral neuropathy. When we distributed them through a simple format, we found out that 85.2% of these patients who have the toe deformities confined to forefoot were of type 1 category, which means we are seeing them, but we believe we should not intervene them. And only 14.8% of these patients had a complex deformity where there was a presence of a callus or underlying ulcer, and none of the patients with type 3 deformity presented to us during this study period. We compared with various parameters, and we found out that there was no association of age, gender, diabetes duration, comorbidity, side of the foot, number of deformities seen in this patient's pathological type, or PVD with any of these type of this. There was no significant association at all. We also saw that the duration of diabetes or presence of comorbidity, side involved, number of deformity, whether it was single or multiple digits, presence of peripheral vascular disease, or gender also was not associated with presence of any of these type of deformities, and they were non-significant. What we noticed was that hallux valgus and mallet toe occur as an isolated single digital involvement, whereas hammer toe and claw toes usually involves more than 2 digits, and they are multiple. The deformities that occur in diabetic foot can occur in forefoot, midfoot, and hindfoot, and we believe that there are various mechanisms responsible for these deformities, ranging from intrinsic muscular atrophy and ill-fitting footwear. Toe deformities are extremely common in forefoot in our clinical practice, and the structural, which are the visible one, are claw toe, hammer toe, mallet toe, hallux valgus, and they lead to abnormally high pressure, and repeated pressure in these areas can result in breakdown of the skin, causing an ulcer. Different studies have shown different varieties of foot deformities in different parts of the world. Ababna series shows hallux valgus to be common. Obgera shows claw toe be hammer common, and Mansoor et al. Shows hammer toe be common, followed by claw toe. And even in our study, we found hammer toe was common, followed by claw toe. Unlike the Western literature, where hallux valgus is extremely common because of the closed footwear, in our country we have open footwear, and that's why hallux valgus incidence has been quite less. If you see, South Indian patients have a habit of wearing these type of footwear, and since intrinsic muscles play an important role in the grip of this footwear, we design that the time when the patient develops motor neuropathy, the function of these muscles get distorted, and hence there's a high chances of hammering on clawing when they try to grip between first and the second toe. Ladies and gentlemen, this simple study shows that foot deformities are common, but they are in forefoot, and type 1 are the deformities which we are seeing in our clinical practice, where hammer toe is the commonest and claw toe is the second commonest. We believe that you should not operate these, since there is a neuropathy and no pain and no ulcer, and they should be given diabetic footwear or splints to manage them. Hallux valgus prevalence, unlike Western, was extremely low in our patient. We believe this simple classification on extended SCC on toe deformity is highly practical and easy to be remembered, that categorizes toe deformity in 3 simple time, and one can use them with the practice and understand the guidelines that when to operate, when not to operate, and made easy in clinical practice. These are my references. Thank you.
Hello.
Yes, sir.
Dr. Jain.
Yes, sir.
I did preventive foot care about 30 years back. I visited one of the Jain hospitals in Bangalore.
I know, sir. Jain Institute of Vascular Science.
Yes, under Dr. Sridhar. Okay.
Yes, yes, sir.
And your classification, whether there is a deformity you have looked into, and you say ulcer is the type 2, and any complication present, that is type 3.
Yeah, if there is an infection of abscess.
Okay. You know, your first presented claw toes.
Yes, sir, claw toes.
You know, when claw toes occurs, it takes 5 to 10 years for the patient to develop claw toes.
Agreed, sir.
That is a late detection.
Yes, sir.
Okay.
Yes, sir.
So, what you should have looked into, it is not only this deformity alone.
Yes, sir.
Other forms of predisposing factors also, if you look into.
Yes, sir.
Say they get the thorn prick before. After that, it leads to callus formation.
Yes, sir.
So callus formation is the most important thing that you are not included. But it will not cause. Who said it will not cause deformity? That place you will have to occupy when you give a protection to that person. You will have to change the shape of the shoe or the chapel that you are going to provide. So please take into this account. You can talk to me later. I will show you. I'll send my things.
Yes,
if you could study the footwear of these patients, you can see the number of deformities that are present in it. Okay.
So you'll get shocked to know that I presented last year in same Diabetes India on Amit Jain's therapeutic footwear for India, and they were also type 1, 2, and 3. This is a continuation of modern diabetic foot, and this is my 17th innovative work. Your callus also we have worked already, and the predisposing factor was introduced on India's first screening tool for diabetic foot called linear foot tests.
Okay. Anyway, we'll see. Okay, I will keep it in mind.
Thank you, sir.
Thank you for your approach. Approach is different. That's all.
Sir. Thank you.
But only 2 deformities. Are there any other deformities?
No, sir. We showed 4 deformities that consist of hammer toe, claw toe, mallet toe, and hallux valgus. The commonest first 2 have been hammer toe and claw toe. Yes. The incidence of mallet and hallux has hardly been 4.5%, which is very less in our Indian population. These are for toe deformities. I'm only including the toe deformities.
I understood. I understood. And under the toe.
And that the only 4 have been included, sir.
Okay, okay. Right on. Thank you.
Thank you.
Next, Madam Manisha, you can ask, present, call for the next speaker. Hello? All right, I will call for the next speaker. Dr. Bharat Shabu from Indore. He will be talking to us on psychosocial disease of COVID-19 pandemic. People with diabetes in central India.
Good afternoon,
yes, Dr.
sir.
Shabu.
Are my slides visible, sir?
Yes, yes.
So a very warm welcome to all of you. And I would like to thank, first of all, the scientific committee and the organizing committee for giving me this opportunity to present my work here. It is titled Psychosocial Distress of the COVID-19 Pandemic, especially in people with diabetes in central India, where actually I practice. So with the background of COVID-19, we all know how dreadful it is and how it has become a global pandemic, and we all are dealing with it. But along with it, we are also dealing with a global epidemic, which is diabetes. So we have more than 463 million adults of age 20 to 79 years, 9.3% of the world's population of that age group, which are diabetic. So there are two things, epidemic and the pandemic together, and there is a higher relationship between diabetes and variety of emotional states as well, which causes a exacerbation of the same in any stressful environment. So diabetes mellitus, we all know, it itself causes distress. It increases the risk of psychosocial distress as compared to the general population. Being a chronic condition, it is associated with more severe COVID-19 disease and worse prognosis. It has been proved. This increases the level of anxiety in diabetic patient per se more than the general population. Now, this concern about the short and long-term psychological consequence of the pandemic, the United Nations noted it, and they said a widespread emotional distress which was prevalent in the COVID-19 affected population. So they called for action on mental health along with this ongoing pandemic relief program. So globally, we have seen with various data that the mental health services have been overburdened and they have experienced greater than usual demand. Now, this distress will actually continue after the pandemic ends. Hopefully, it ends soon, but the psychological distress will continue even after it. The psychological distress will peak at a later point after the health or the ill health peak is gone. It will last longer than the physical health consequences as well. This is expected, and we all know it. So the aim was to survey the COVID-19 related concerns and the psychosocial health among the patients with diabetes during this second wave of COVID-19 pandemic in central India, and specifically to explore and characterize the people with diabetes who are at higher risk or those who have a high level of concern, so they can be dealt early, because we have a scarcity of healthcare professionals in all regards. So the method was very simple. It was a survey conducted by online questionnaire. 750 odd adult numbers were enrolled in this. They were all adults more than 18 years of age, 340 odd females, 400 odd males, and they were all people with diabetes who consented to share their information about their life and diabetes with us. Now, the inclusion criteria were very simple. They should have diabetes, either type 1, type 2. They should be adult more than 18 years of age. They must be living in the central India, because to make the sake of data, we centralized it to the central India only. The exclusion criteria were diagnosis or history of any mental illness in the past. They were excluded because the stress parameters can be affected by that. Now, the questionnaire included questions on COVID-19 related concern, fear related to their disease itself, socio-demographic and health status after the consent of the patient, social relations after the consent, diabetes specific social support, and the stress score was calculated using the perceived stress score 10. So the responses were analyzed and statistical analysis was done using Excel. Now the results were like we expected on the same lines. The diabetic patient had a high level of stress, but on sub-analysis, we found that most were worried about being severely ill due to diabetes if infected with COVID. That was the most common concern amongst all of them. While 34% thought that their diabetes will not be properly managed if they become infected. They all had a high stress level. The mean PSS score was 25, indicating moderate stress level across all the subjects who were studied. On sub-analysis, we found female to be more stressed than males, which was reflected by a higher PSS value. The type 1 patients were having a higher stress level as compared to the type 2 patients. The patients who were having a complicated diabetes mellitus, which was defined by having 2 or more micro and macrovascular complications along with diabetes. So complicated were having a more PSS score and more stress as compared to uncomplicated diabetic patients. Those patients, those who were living with family, had lower stress score as compared to the patients who were living alone. This was a startling fact which came out. And on the contrary to the last year, it was something unusual where we found more stress among the rural population as compared to the urban population. To conclude, we all know COVID-related concerns with diabetes can lead to psychosocial stress, and a poor psychosocial health can lead to metabolic derangement, which will make healthcare professionals' job much more bulkier. So based on this survey, we can analyze the need of individuals with diabetes, actually what they want, what are their individual needs so that they can be tackled. Their individual concern based on the specific questions, they should be addressed and they can be addressed very easily. We can arrange the counseling session for those who have a very high PSS score or those we found at risk so that we can help them. And we can also help them through support groups, those who are alone or not having any family support with them, so that they can have at least a support group and their apprehension and fear and anxieties can be brought down. But there is a lacuna in this study. I would admit that further work in this area through a wider data collection through multicentric study is required because this sample doesn't reflect most of the India. It is only confined to central India. And the address of this aim of this study may assist healthcare professional in first safeguarding the psychosocial well-being of the chronic patient, especially our persons with diabetes who are at more risk, and preventing the metabolic derangement which can occur due to the same in the face of a pandemic which is still ongoing. With that, thank you, sir.
Okay. Thank you, Doctor, for a presentation on psychosocial issues in patients that type 2 diabetes or type 1 diabetes with the COVID. Is that all right? I would like to know, where did you catch this patient? As an inpatient or as an outpatient?
Sir, it was an online survey. So from the registry of patients, we sent an online questionnaire first with the consent. Those who consented, they were sent the form. Those who filled the form, then it was analyzed.
Okay, that's very good. Then why did they have so much of fear? You know why? It is the media.
Yes, sir. Actually, this is also one point which came up, which I have not put in here
Yes,
because it is a very controversial issue. Those who were watching television for 6 hours or more, they were more stressed than those who are not watching television. This was a startling fact which we found out.
In fact, we have started, my colleagues, my students are professors now. They are all studying these aspects in medical colleges. They found most of the diabetics doing very well. But the one point that you have made, 62% had distress about severity and 34% were worried about their care of diabetes.
Yes.
That I agree. You know, they do morning blood sugar and only evening blood sugar.
Yeah.
This is almost all. If it is more than 200 only, they will give insulin. Okay, all the 2 times.
Yeah.
But many patients who were mine and doctors who studied under me, they all used to contact and I used to suggest the dose because they know how to take insulin. And they were having machines. You have not only studied, you have studied the psychosocial aspect and you should have advised them how to take care of your blood sugar. What should be the level? If you have told them, the paper would have been very best. But I appreciate that you would have, no, that is more important. Keep your blood sugar below 120, 100 to 120 fasting. I always say 100 rupees and 150 rupees. 100 rupees before each meal, 150 after each meal. Very easy to remember. HbA1c, how many days per week? 7 days. So HbA1c below 7.
Actually, I'm very sorry to say, sir, but that data I have already submitted to EASD. That's why I am not able to submit it here.
No, you can present. No, without studying the blood sugar. Suppose if the blood sugar is high, he is also worried much more.
And
Okay.
actually, this was actually done, sir, to allay fear of our patients only. But we first wanted to find out what are the actual fears.
But
So that we can...
if you study psychosocial aspect itself, is a great thing, doctor. People are looking the minds of others. That is what is important for a professor like me. Thank you very much.
Thank you, sir. Thanks a lot.
And thank you. Next paper. Oh my God, I have gone off. Next paper by who is there, please? There is Annie Phillips. Is she presenting the paper? Manisha, can you find out?
Yes, sir, she's here.
No, she is supposed to come now. If she is there, please ask her to.
Annie is here.
Oh, okay, madam. She is going to talk about reaching out to share the best practice with an India-UK partnership for advancing diabetes care.
Annie, can you please increase the volume of your laptop because we are not able to hear you. No, we are not able to hear you. No, can you increase the volume of your laptop or maybe use earphones?
Will you get ready? Can I ask another person, please?
Is that any better?
Yes. You are welcome.
Perfect.
Go ahead, please.
Thank you. Can you see my slides?
Not yet. We can see you only.
We can see me only. Right. Can anyone help to get them on presenter mode, please?
If the organizer have the slides, please put on.
So, ma'am, there is a share screen green button. When you scroll your mouse on the Zoom, you will see all the buttons at the bottom of the screen. You just have to click on share screen.
Aha. Yep. There we go.
Yeah. A window will open and you can see multiple small windows in that. And in
Yes.
Yeah.
We're there?
Yes, good.
Lovely.
Come to presentation mode, please.
Yes, there we go.
You can come to present. Yeah, good. Very good.
Yeah, good. Okay, thank you very much for your help. And thank you very much for inviting me on behalf of my team today to present to you. I work at Birmingham City University and also the NHS University Hospitals in Birmingham, along with my colleagues who are part of the collaboration who designed this MSc programme, but also who deliver the MSc programme accordingly. So our teaching faculty is Professor Wasim Hanif, who's our medical director and head of diabetes service. I'm Dr. Anne Phillips and I'm the programme leader for the MSc. Professor Mahendra Patel is a visiting professor and clinical pharmacist, and I know he's presented many times in India. Jane Robbie is a senior lecturer, specialist podiatrist, and a Diabetes UK clinical champion, which means that she's been recognised for excellence in her clinical practice. Martha Stewart is a senior lecturer and diabetes specialist nurse, and Teresa Smythe is a consultant diabetes specialist nurse. So she's right at the top of diabetes specialist nursing in her trust, and she's an honorary professor within the programme. So we make up a very collaborative team together, and we all represent different aspects of diabetes care for our students. So our students are all medical doctors and they all come from every region across India. And this is really important because we aimed through this programme to reach out accordingly to rural, community, urban and inner city diabetes services. We also aim to reach doctors at varying levels of their diabetes experience. Some are very experienced practitioners, some are newer into practice. And by networking and collaboratively working together, they've been able to share good practice with each other, but also network across India, which they might not have had necessarily the opportunity to do so previously. So the ethos of our programme is that it's a collaboration, and it's a collaboration between the UK and India. It's a collaboration within clinical practice, and the whole concept of the programme is about improving and advancing diabetes care accordingly. So we've also got to think of the practicalities of service development and effective communication. How do we reach our local populations? How do we reflect the diabetes care for the local populations where the students are practicing within? And that's been very, very good for them to critically examine how to reach out into maybe harder to reach populations accordingly with diabetes care and diabetes prevention strategies. We've enhanced individualized communication using language matters all the way through the programme, and certainly that's been really beneficial in watching and seeing the students develop accordingly. We've also embedded culturally appropriate diabetes care, and the students are core to this programme. So they network, they take part in regular webinars, they feed back, and they examine case studies together and do some group work. So that's really good because we've got the mix of environments and resources enabling them to enhance their practice. We think about interdisciplinary service developments as well, and trying to support students who are sole practitioners to understand and get ideas from group practices too, and about expanding their services with a view to multidisciplinary diabetes care delivery. So the progression for the first year is a postgraduate certificate, then a postgraduate diploma for the second year, and an MSc. And students can step off at any point in the programme. And in particular, during the last year, it has been a challenge for students, but we're delighted to say that the students have really succeeded well and invested well in themselves and their studies alongside their work with COVID-19. Our programme is a mixture of clinically focused opportunities through modular development. And the first year is embedding clinical practice around key concepts and presentation in diabetes, particularly pertinent across India. But also in the second year, we're starting to prepare students for their dissertations. And we do give them some options of modules of what they may like to choose. Student feedback has been phenomenal for this programme, so we've been delighted as a team, and these are just some examples of student feedback that they have shared with us. Inspires me to achieve my best, invests in CPD for me. I love the variety of learning resources, keeps my mind stimulated and learning, whereas I might not have had an opportunity to do this. My diabetes service has grown as I take new approaches back to my service and to care, and we see that demonstrated in the assignments and assessments and certainly group work that the students discuss with each other. Very new and up-to-date approaches and ideas, and that's to embed emerging evidence also within the importance of emerging evidence also in the importance of diabetes care delivery. Excellent feedback offered, and really to encourage people, you give them feedback and you give them constructive feedback and try to support their learning accordingly going forward. The interactive webinars have been really, really useful. It's brought the students together, and as you see from the students coming from right across India, they've had the opportunity to get to know each other and get to know other areas of diabetes care delivery, which they might not previously have had the opportunity to do. Thinking about investing in education and supporting their learning, but really just trying to provide them the best learning experience that they can invest in themselves. But we couldn't have done this without some reciprocity. And reciprocity is important to understand the needs of the students. They're all medical practitioners, so they're all very highly qualified in their own right, but also the reciprocity of what we can also learn from our students as they can learn from us to try and advance diabetes care, advance diabetes practice, but also to bring some exchange of ideas of what works well from South Asian diabetes populations, but also into UK diabetes populations, and thinking about the reciprocity accordingly. And that's been enabled really, and we're very grateful and thank you to be able to support us with this. We've been very lucky to have all the students to be sponsored by Lupin Pharmaceuticals. So apart from their time and their investment in their education, there's been no financial cost to them to gain these qualifications. And that I think is really important. We know it's an ongoing relationship with Lupin Pharmaceuticals to support future students accordingly, invest and advance their diabetes care. Thank you.
Thank you, Anne. Thank you, Madam Annie.
You're very welcome.
This is something surprising. In a research paper, you brought in education and cultural exchange. Hello, please close
Hello.
this. Please close the next presentation. Hello. Okay. That is fantastic. You wanted to have a person centralized approach. Person with a diabetes centralized approach with effective communication. You have understood language barriers in that, in communication. And you had 3 programs, no? Three certificate programs.
Yeah.
Or is it degree program?
They are all master's degrees, but it's as you move up through and gain more academic credit, then you gain the qualifications. So you gain a postgraduate certificate, postgraduate diploma, and MSc.
They have to come direct to your Birmingham.
It's all online. It's all delivered online. So all the students are based in India and are practicing in India.
So it is online.
Yes, all online.
You know, we used to call CARE, C-A-R-E, diabetes care, clinical application research and education.
Yeah.
That is the meaning for CARE. And a teamwork.
Yes.
And the nurse educator is the most important person in the field. I understand that. And way back in 2003, 2000, I started a diabetes nurse educator course for our nurses in various parts of Tamil Nadu.
Yeah.
As such, this has not taken a place in India. I think this partnership should go forward. And it is a knowledge exchange program. I think keep going. Wish you good luck. And we will also benefit. We will also benefit from them. We means our Indian people should get benefit through your educators. Okay, thank you.
Thank you.
Next, Dr. Vijay Patni.
Yes, sir. I'm there.
You are from Calcutta.
Yes, sir.
You will be talking on prevalence of hypertension and type 2 diabetes mellitus in primary care setting in East India. Good. You said primary care setting. That is an attracting word, sentence, and the study. Please go ahead.
Thank you, sir. Thank you, chairpersons, and thank you, organizing team Diabetes India, for giving me this opportunity to present my study in this particular section of the conference. So the thing is that we are going to discuss, or I'm going to present a cross-sectional study on prevalence of hypertension and type 2 diabetes in primary care setting, but it's more in setting of my own clinic in Calcutta. It's not absolutely, I won't say it's Eastern India. So all of us are aware about the deadly duo of diabetes and hypertension is the commonest comorbid condition in diabetes and vice versa. In patients with diabetes, 75% of all cardiovascular disease is attributed to hypertension, And in type 1 diabetes, hypertension is usually the result of underlying nephropathy, whereas in type 2 diabetes, hypertension usually coexists with other cardiometabolic risk factors. So this is where the problem lies. Diabetes and hypertension have a common link. The link is insulin resistance, and that is where it can lead to various other factors which can lead to increased atherothrombotic risk. And that is the whole crux of the problem. So whenever you have this deadly duo, probably you'll end up with more of cardiovascular and chronic kidney disease. And that is very important. And this is what the whole idea was. So where do we stand actually? So contributors to hypertension, obviously genetic factors, acquired factors like central adiposity, ectopic lipids, and environmental factors. But ultimately, they all lead to insulin resistance. And this insulin resistance is basically the grassroots of three important demon, that is hyperglycemia, dyslipidemia, and hyperinsulinemia. And hypertension in diabetes is related to this hyperinsulinemia because it is linked to the increased renal reabsorption of sodium, along with increased sympathetic tone and along with RAS activity. But you add on to that is obesity, aging, and renal disease, which can further increase the prevalence. So we wanted to look into the prevalence of hypertension primarily. And the aim was to study the prevalence of hypertension and type 2 diabetes in our setting. This whole idea was conceptualized actually on World Heart Day last year. And the idea came out because we were planning for a course that was hypertension certificate activist program conducted by Indian Society of Hypertension, and I was part of it. So we started that on 29th of September 2020, and it took us almost say about 4 days planning it out. And we acquired new instruments, the validated blood pressure instruments and the glucometers, along with training of the nursing staffs. So this was a cross-sectional observational study, which followed a convenience sampling method in a primary care setting between 1st October to 20th October. The samples were drawn randomly. There was no cutoff age or BMI. There was no study-specific visit. So that was, the data was only recorded during the routine visit to the clinic. These sisters or nurses who were trained, they were trained in a proper how to measure the blood pressure properly as per the guidelines. All the patients coming to our clinic were studied and evaluated for blood pressure, and plasma glucose measurements were done simultaneously in the same set of patients. Along with that, what we did was we made a physical examination, particularly the height, weight, and BMI, and did inquire about any history of hypertension, diabetes there in them. Because if you remember, this was just post-lockdown, sometime in the month of September. So obviously, we only entertained people coming from 5 to 10 kilometers of our clinic. So it was mainly an urban population, right in the center of the Calcutta city. And we did not encourage rural population to come for physical appearance during that time. So before I really go into the study part, what we know from till date, I can just quote you two of them. One was Priya et al., who came out with the prevalence of hypertension to about 42%, and Ramchandran et al. In his own study said about 38% was the prevalence of hypertension. And we all are aware that the hypertension is about twice as frequent in diabetic than in non-diabetic. So these are the basic stuff. But I've got, along with that, if you see the recently published article in the International Journal of Hypertension, there was a meta-analysis and systemic review where Navi et al. Actually presented this particular paper. And what he concluded that the prevalence of hypertension was a tune of about 33.98% in Asian population, vis-a-vis globally prevalence was about 31.1%. So what we did was blood pressure was recorded in sitting posture in the right arm using all the standard measuring tools, and we used a standard arm-down oscillometric BP device with appropriate cuff size. And then hypertension was obviously defined as average of two readings recorded 3 minutes apart with a systolic blood pressure more than 140 or the diastolic blood pressure more than 90 or equal to. The data was collected and entered in Excel sheet and statistically analyzed using statistics software statistical package for social services. And the results were that a total of 785 patients were included in the study, among which 478, that's up to about 64% were males, and 278, that is about 36% were females. And the mean age of the patients were 55.4 plus minus 8 years. And the total of 276, that's about 35% were of normal BMI. Rest were either overweight or obese. Obese constituted about 32.1%. And what we saw that the prevalence of hypertension was noted in about 32.73% patients in overall study population. This was just an urban population, so we cannot conclude that overall population, overall prevalence of the whole society. In the overall cohort of 785 patients, the BP was normally is about 31%. About 35% patients were pre-hypertensive. About 18% were stage 1 hypertension, and stage 2 hypertension about 14.27%. Thereby, the result was about, we had about 32 in this study population, 32.73% hypertensive population. Among them, a total of 122 patients were found to have a blood glucose value of 200. This was basically measured by glucometer, and that was a Roche machine which we used, or more, and 40 patients were already known type 2 diabetes. In hypertensive group, actually, there was about 156 patients who were known hypertensive. So that constituted about roughly around 20% of the patients. Thereby resulting in this diabetic patient resulted, the prevalence was about 20.63% in this particular study group. Out of these 162 patients with diabetes mellitus, 39 patients were normotensive, that was 24%, 48, that is 29% were pre-hypertensive, and the remaining 75 were hypertensive, that is about 46.29%. So we can conclude that we see a higher prevalence of hypertension in the subgroup of diabetes patient, 46.29% versus 32.73 in the overall studied population. Probably, as far as diabetic population is concerned, most of the other studies have a variability right from, say, around 50 to almost 70% in different study groups. So this is what we found as far as our results are concerned. So I would like to go for the conclusion that from the above study, we would like to conclude that prevalence of hypertension increasing in patients with diabetes mellitus. Presence of hypertension along with diabetes mellitus increases the complication and twofold rise in cardiovascular disease-related mortality. Therefore, this deadly duo needs special attention. Therefore, screening for hypertension in diabetic patient is a must, and as also in general population, so that early identification and management can be planned out, which in turn will favor good outcome in patients, including the good quality of life. Thank you.
Thank you, Dr. Vijay Patni. One thing, you have studied from your clinic patients.
Yes, sir.
And you are an MD, general physician.
No, I am an MD.
Please tell me.
Basically, I'm a consultant diabetologist. So,
okay, okay. Thank you very much. Thank you very much.
Thank you, sir.
In 20 days, you were able to detect so many patients.
Yes, sir.
In 1 year, how many diabetes you will get, and you see, you said rightly, deadly complication. We call it as diabetes and hypertension are silent killers. And you talked about Hypertension Society of India. Okay, yes, you are a member in that.
Indian Society.
You know, last month, masterclass series on hypertension was conducted by Indian Medical Association throughout India. For entire month, hypertension classes were taken on all aspects. If you want to see go to IME and click on hypertension, you will see the whole talk on hypertension. But I very much appreciate you for taking this for 20 days. Please do it for the entire year. And I hope you would have written about the duration of diabetes and the complications that have occurred. You have just looked into present prevalence of hypertension and the diabetes, and about 60%, both pre-diabetes and pre-hypertension and hypertension were present. I think an alarming rate. Thank you for bringing out that alarming thing. And it's not only an eye opener; it is already established, but it must be more looked into by all practitioners in diabetes, physicians, diabetologists, general practitioners, and take appropriate action. Thank you very much. Thank you.
Thank you, sir.
And next one, Dr. Amar Kamil Kali Ahmad from Saudi Arabia. Has he come?
Yes, 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 my professor.
Are you ready, doctor?
Ready? You hear me?
Yes. Which
Thank
part
you.
of Saudi Arabia you are?
Ministry of Health. I am Egyptian, but I work at Ministry of Health, Saudi Arabia, Riyadh.
Okay. I was in Riyadh in 1985. That's why I asked you.
Welcome.
Okay.
Welcome, professor.
You are going to talk about obesity, type 2 diabetes, COVID-19, or closed case. Is metformin is joker drug?
Yes.
That is allowing. Anyway,
Yes.
please proceed.
Welcome for all. I am very happy.
You must be loud or make your sound system more.
Yes, yes. Many thanks for all, and take a chance for my presentation and very nice conference. Okay. Obesity, type 2 diabetes, COVID-19, closed key, is metformin is the joker drug. Obesity body mass index more than or equal 30 kilogram per meter square. Obesity worsen outcome from COVID-19. Adults with excess weight are at even greater risk during COVID-19 pandemic. Having obesity increase the risk of severe illness from COVID-19. People who are overweight may also be at increased risk. Having obesity may triple the risk of hospitalization due to COVID-19. Obesity is linked to impaired immune function. Obesity decreases lung capacity and reserve and can make ventilation more difficult. A study of COVID-19 cases suggests the risk of hospitalization, intensive care unit admission, invasive mechanical ventilation, and deaths are higher with increasing body mass index. The increased risk for hospitalization or death was particularly pronounced on those under age 65. More than 900,000 adult COVID-19 hospitalization in the United States of America between the beginning of pandemic and November 18 to 2020, estimates that 30.2% of these hospitalizations were attributed to obesity. COVID-19 death rate are 10 times higher in countries where more than half of the adult population is classified overweight. A comprehensive report from the World Obesity Federation has found. The report from Johns Hopkins University and WHO Global Health Observatory data 2.5 million COVID-19 deaths reported by the end of February. 2.2 million were in countries where over half of the population is classified as overweight. Taking data from 160 countries, report found linear correlation between countries' COVID-19 mortality and the proportion of adults that were overweight. There is not a single example of country with less than 40% of population overweight. Vietnam, for example, had the lowest death rate from COVID-19 in the world, 0.04 per 100,000, and the second lowest level of population overweight at 18.3. The UK has the third highest death rate globally, 184 deaths per 100,000, and the fourth highest prevalence of overweight at 63.7%. United States has the next highest rate at 152.4 deaths per 100,000 and has 67.9 of the population overweight. Overpopulation are more susceptible to respiratory disease generally during the MERS, Middle East respiratory disease, and H1N1 influenza epidemic, for example. Worse outcome were linked to excess body weight. Tim Lobestin, the report's author, said we now know that an overweight population is the next pandemic waiting to happen. Look at countries like Japan and South Korea, where they have very low level of COVID-19 deaths as well as very low level of adult obesity. They are prioritized public health across a range of measures, including population weight, and it had paid off in the pandemic. Tedros Adhanom, Director General of WHO, the report must act as a wake-up call to government globally. The correlation between obesity and mortality rate from COVID-19 is clear and compelling. Investment in public health and coordinated international action to tackle the root causes of obesity is one of the best ways for countries to build resilience in health system post-pandemic. Type 2, next step, type 2 diabetes and COVID. There is here, this graph show the COVID-19 in relation to diabetes and obesity, the prevalence of diabetes in hospitalized patients, 31.8% versus 5.4% in non-hospitalized patients among COVID patients. And obesity, 39.8% versus 14.5% among hospitalized, 39 versus 14.5% among non-hospitalized patients. This study at France, observation study, included 126 patients. The frequency of obesity was 47.5% compared to 25.8% in control group of among ICU patients with the SARS-CoV versus control group. Obesity increases the risk of hypoventilation syndrome in ICU patient and can lead to respiratory failure when acute respiratory distress syndrome is present. The likely mechanisms that explain this effect are poorly understood, but mechanical and inflammatory factors might contribute, like Dr. Abi before session today speak about obesity and inflammatory leptin and inflammatory factor like interleukin-6. Finally, according to the Cross et al., 74% of diabetic patients were obese, which may have contributed further to the increased risk observed in this population. In general, people with diabetes are at higher risk of developing complications because infection, particularly viral one. The difference in response are likely the result of the degree of the viral load, host immune response, age of the patient, and the presence of comorbidity. The higher risk of mortality and complication among people with diabetes was similar in the two other recent coronavirus outbreaks, the SARS and the Middle East. Type 2 diabetes is associated with low-grade chronic inflammation induced by excessive visceral adipose tissue. This inflammatory condition affects the hemostatic glucose regulation and peripheral insulin sensitivity. Chronic hyperglycemia and inflammation can determine an abnormal and effective immune response. Diabetic patients with COVID, higher risk of being excessively hypercoagulable state, uncontrolled inflammation and response. Diabetes risk factor for worse outcome because absolute count of neutrophil, some inflammation related biomarker like interleukin-6, serum ferritin, ESR, CRP, and D-dimer all high. But absolute points that the absolute count of lymphocyte, also red blood cells and hemoglobin level significant lower in diabetic group than in non-diabetic group. It is crucial to outline that levels of enzyme like lactic dehydrogenase and alpha hydroxybutyrate dehydrogenase ALT, and indicating the injury of myocardium, kidney, and liver were higher in patients with diabetes than patients without diabetes. This data provide a clue that injury of organ was much more severe in diabetic group than in those without diabetic. Chest CT imaging of COVID patient with or without diabetes compared. The latter with the beta showed more several pathological changes than the former. To confirm this, the beta group present higher CT changes than other normal one. Now we speak about the very important drug, the cheap drug, history of metformin since 1920 year used for antiviral like influenza, for antidiabetic and for influenza, and then forget because insulin discovery, but come back for usage at the 1994 at America FDA approved. The history linked to Galegia officinals go through traditional herbal medicine in all found to rich in guanidine, lower blood glucose, metformin used to treat diabetes and discontinued to toxicity, and then come back rediscovered and used for influenza agent in 1940. The safe, well-tolerated, and economical antidiabetic drug metformin could prove to be beneficial for COVID therapy in multiple ways and improve a treatment outcome and reduce mortality in COVID patients. Metformin decrease blood glucose level, increase insulin sensitivity, and could possibly inhibit viral infection, multiplication, and maturation, inhibit translation of viral protein. This protein, which in protein, casein L protein, which is used by virus for replication at the surface of the cell and inside the cytoplasm of the cell. We will see as the next slide. And modulate inflammation and immune response. Metformin inhibiting the expression of neutral factor kappa gene eliminates the susceptibility to common disease. Metformin can exert direct vascular anti-inflammatory effect by inhibition of neutral factor kappa and reducing elaboration of the pro-inflammatory cytokine like interleukin 6, also said before Dr. Abi as today, and interleukin 8 from activated smooth muscle. Inflammation participate in coronary heart disease. White blood cells count and level of C-reactive protein predict the incidence of type 2 diabetes. So obesity elevate level of inflammatory cytokine considered mediator of increased cardiovascular morbidity. Cytokine such as interleukin 8 likely contribute to monocyte recruitment and adhesion and sclerosis. Whereas interleukin 6 drives the acute phase response. When patient with COVID at recent infection, you have fever. Why? Because interleukin 6 is high. This study demonstrates that metformin inhibit interleukin 1 induced interleukin 6 and interleukin 8 expression. We do in silico molecular docking in review study by British University. Our team was Dr. Simona at Egypt because to see what's bond between the zinc and metformin. We can see the molecular docking of the combination zinc and metformin and how to inhibit the casein L. We can see here the compound with the blue with dark blue color, this and zinc metformin, this ring, and you can see two bond bind with casein L cysteine 25 with bond 3.8 angstrom.
Doctor, please conclude quickly.
Yes, and you can see the bond from metformin at hydrogen bond with oxygen of aspartate 162 with distant 2.5. Inhibitor effect for metformin, you can we said casein L inhibition. Zinc with metformin complex may be promising inhibition of cysteine protease inhibition, molecular docking of casein.
Your conclusion, please.
Yes, this table, this summary, obesity is the gate for future viruses as linked to diabetes, inflammatory state, difficult ventilation at ICU, and many chronic disease. Any drug help to overcome obesity will be helpful at reducing the worsening of the SARS-CoV-2. Metformin is a joker drug for diabetes, for obesity, and lower insulin resistance and inhibition of caspin L, a protein used by COVID-19. Metformin is not alone, but love another metal, which is zinc through metformin zinc complex, is promising complex for future clinical study, have 3 bonds for strong inhibition of caspin L used by COVID. This is our study in Silicon at British University. Thank you for Dr. my professor and all teams of the conference. Thank you, and Allah bless India. Thank you very much.
Thank you, Dr. Ahmed, for bringing out a good review. You brought out a review of COVID, obesity, and metformin. Okay.
Thank you very much. Thank you.
And why did you name it as a joker drug? It's a best drug available. But you see, when we are treating COVID patients, those who are all controlled with metformin are allowed to go with the same drug in COVID wards. Okay.
Yes.
If
Yes.
their blood sugars are not rising.
Yes.
But if the blood sugars are high, more than 200 fasting, then definitely we go for insulin.
Yes. Yes. Yes.
Okay. But what you have given a review of articles. Okay. In a research paper setting, you must do your work and confirm this and then present in next meeting somewhere.
Yes.
COVID patient, you have given metformin. No protocol will allow you to use metformin for all patients.
Yes. Yes.
Okay.
Okay.
Thank you. Thank you very much, Doctor.
Thank you very much, sir. Thank you.
Dr. Sankat Panse is ready.
Yes, sir.
Dr. Sankat Panse from Nagpur.
Yes, sir.
I am remembered of my friend Sarat Panse.
Yes, sir. I'm his son.
He is your father.
Yes, sir.
Tell him Professor Sundaram from Chennai.
Yes, sir. Sure.
Dr. Sam G.P. Moses assistant. Okay.
Yes.
Right. You are talking about charcot foot. It's a late complication of diabetic polyneuropathy. And
Yes,
what
sir.
message you are going to give you, we will see.
Yes,
The
sir.
stage is yours.
Thank you, sir. At the outset, I would like to thank the organizers for extending this opportunity to me. And are you able to see my slides? I will share them again.
No. Please share your slides.
Yes. Yes. I will share them again. Yes. Are you able to see my slides, please?
Yes.
Yeah. Thank you so much.
Yes.
So my topic,
Visible.
my topic is charcot foot as a late complication of diabetic polyneuropathy.
Okay.
So I will begin with this brief overview with the definition of charcot foot, which is defined as an inflammatory condition which affects bones, joints, soft tissues of the foot and ankle, and it is characterized by dislocation, fracture, destruction of the foot architecture. In simple words, it has been defined or it has been explained or described as a loose bag of bones. The joints become flail. The foot can move by almost 180 degrees, and the foot is highly susceptible to develop chronic non-healing neuropathic ulcers. Patients can develop infections, and it is also a high-risk foot for lower limb amputation. The prerequisite for development of charcot foot is presence of peripheral neuropathy with loss of protective sensations like pain, touch, and position sense. And often in clinical practice, we come across a lot of misdiagnosis of charcot foot for cellulitis or gout or some other conditions like DVT, etc., or a simple sprain, which leads to a late diagnosis due to lack of clinical suspicion. And I will be presenting 4 brief cases, snapshot of cases, primarily focusing on having a high index of clinical suspicion for charcot foot and detecting this condition as early as possible. So the first case is of a 48-year-old gentleman, a forest officer in Madhya Pradesh, presenting with bilateral edema feet for 4 months, more on the right as compared to left. He also had typical symptoms of bilateral symmetric peripheral neuropathy for past 2 to 3 years, and a history of diabetes and hypertension for past 5 years. On examination, he had loss of all modalities of sensation like touch, pinprick, and position sense, and his ankle brachial pressure index was normal. Now, this is the clinical picture of his foot. One can readily see that there is more edema on the right foot. There is also a small bulla on the right great toe, and his clinical investigations revealed an HbA1c of 8.5%, indicating a poor control of diabetes, and elevated creatinine, macroscopic albuminuria, and moderate anemia. So, with this history of nearly painless edema of unilateral edema or more on the right side, we asked for an X-ray which revealed a staggering 7 fractures in his foot. There were multiple fractures where you can see at the metatarsal heads of second, third, and fourth, as well as destruction of the tarsometatarsal joints and dislocation of the tarsometatarsal joints. On repeated questioning, this patient did not have any history of obvious trauma. The only job he was doing was of a forest officer, which included a lot of walking around in the forest, but there was absolutely no history of trauma, no history of any sprain of his foot or anything. So with this background of peripheral neuropathy, a painless edema foot, mostly unilateral, it clinches the diagnosis of Charcot foot. I will move to the second case, which is of a patient who presented with thermal injury. A 65-year-old gentleman, farmer by occupation, having diabetes for 10 years, and again he had symptoms consistent with peripheral neuropathy for a duration of 1 year. On his examination of feet, he had loss of protective sensation like touch, vibration, and position sense. This time he presented with thermal injury to his left foot while working barefoot in his farm. And this is a very typical picture of a thermal injury. One can see that the skin has got removed because of the thermal injury, and there is a clean superficial ulcer in his left foot. But what was more striking in this patient is that his right foot appeared edematous. There is a bulge on his lateral border. If we compare to the left foot, there is a bulge on his lateral border of his right foot, and the foot as such appears edematous. This patient had absolutely no symptoms pertaining to his right foot. He was not interested in getting examined or evaluated for his right foot edema. But on insistence, he agreed to do an X-ray of his right foot, and this was the X-ray which showed that there was a fifth metatarsal shaft fracture and a lot of destruction of his tarsometatarsal joints. So again, this is a classical picture of Charcot foot, which remained asymptomatic. Patient continued to work in his farm, and most likely, if this X-ray was not done, he would have presented with a non-healing ulcer, a completely destroyed foot or destruction of his foot architecture, and probably requiring some kind of amputation or debridement. So this patient was saved from all those kind of adverse outcomes. Third case is of a 65-year-old practicing lawyer who had diabetes for 20 years and had evidence of triopathy. He presented with 1 month of foot edema of his left in his left foot. He had very minimal pain, and hence he continued to walk, doing all his activities, practicing his law, etc. He was treated symptomatically elsewhere with furosemide but had no relief, so he came back to us. This time we did an X-ray of his foot, and it revealed a single fracture of his shaft of the second metatarsal. So there was no destruction of any other joints, and this can be called as an early detection of a late complication in a patient who has got dense peripheral neuropathy and long duration of diabetes. Again, this patient had absolutely no history of trauma at all. The last case is of another patient who was 45 years old, having type 1 diabetes for very long time of 25 years. And this patient was working in a small factory where he was supposed to stand for prolonged hours. and he presented with 1 week history of mild pain, but was able to do all his activities of daily living, and edema of his left foot, which was mild edema. Again, he had no history of trauma. There were no signs of cellulitis. There were no systemic complaints at all. And in this, again, patient, we got an X-ray done. The only finding, this patient had a small, some kind of a compressed fracture of proximal phalanx of second toe. So this is also 4-foot Charcot at a diagnosed at early stage. And if we treat it early, then we can prevent development of deformity in such kind of patients. So with this, I would like to move ahead to in a brief about 1 or 2 slides about Charcot foot. So once the initial fracture or dislocation occurs, because of lack of pain due to peripheral neuropathy, patient continues to walk. This walking leads to further fractures, dislocations, and ligament ruptures. This leads to development of inflammation. Because of inflammation, the osteoclastic activity is more as compared to osteoblastic activity, leading to more osteopenia. More osteopenia leads to more susceptibility to fracture. So once a single fracture occurs, the patient enters into such kind of vicious cycle. The perpetuating factor for this vicious cycle is continued ambulation, and this occurs because of lack of pain. If we consider a patient who does not have neuropathy and develops a traumatic fracture, he cannot even keep his foot for a second on the ground because of severe pain which is associated with any other traumatic fractures. And in majority of our patients, the diagnosis is clinical. One should suspect Charcot foot in a patient with long duration of diabetes presenting with common unilateral edema foot, which is having either painless or minimal pain. In the acute stage, patients can have a raised temperature of the affected foot, which can be more than 2 degrees as compared to the other foot. Any patient with diabetes, neuropathy presenting with deformity, one should suspect Charcot, and any patient who presents with a mid-foot ulcer, which is a atypical site for a neuropathic ulcer. Neuropathic ulcers are more common in the forefoot or maybe on the ball of the heel. But in the mid-foot area, if there is ulcer, it is almost pathognomonic of Charcot foot. In patients who have high index of clinical suspicion, X-ray is not showing any features, then one should proceed with MRI foot, which is a very sensitive tool to detect Charcot foot even before a fracture occurs. And the treatment is primarily immobilization for prolonged periods, sometimes from 3 to 12 months, with the help of a total contact cast, or sometimes we can also use a removable cast walker like this. Subsequently, once healing is achieved, bony fusion occurs, then the patient is advised a customized footwear and lifelong limited ambulation. So with this, I would like to conclude my talk, and I would like to say that walking is prescribed for each and every patient with type 2 diabetes, which is one of the first line treatments for type 2 diabetes management, which is also a boon for most of the patients, but occasional patients who have got dense peripheral neuropathy, it can turn to be a bane by leading to complications such as Charcot foot. Thank you very much.
Hello.
Yes. Hello.
Thank you, doctor. What is the message you want to give it to us?
The message is to have a high clinical index of suspicion in patients with type 2 diabetes and to suspect Charcot foot and diagnose with the help of an X-ray.
Okay, doctor.
Yeah.
This should be prevented. Please find out what are all the risk factors that lead to Charcot foot. Can you prevent that at an earlier stage? You have presented a patient with 5 years, 10 years, 20 years, 25 years.
Yes, sir.
A research paper should show something you can detect earlier. Please attempt like that.
Sure, sir.
Okay?
Yes,
Thank
sir.
you.
Thank you, sir.
Next person, please.
Hello, Dr. Sundaram. I'm Dr. Ritesh Gupta. Can I introduce the next speaker?
Yes, sir.
Yeah. The next speaker is Dr. Ashok Golani, and he is from Mangalore, and he's going to present on study of the effect of dental occlusion on mastication habits affecting postprandial glycemic levels in type 2 diabetes mellitus patients. So, Dr. Golani, please present your slides.
Sir, am I audible, sir?
Yes.
Yes.
Yes, sir. And are my slides visible, sir?
Yeah.
Okay. I'll quickly just get on to the presentation, sir. Yes, so my name is Dr. Akash Golani, and I'm a third-year postgraduate of internal medicine in KMC Mangalore. Thank you to everybody for giving me this amazing opportunity to present at such a prestigious conference. Going into my title directly, it is basically to study the effect of dental occlusion on mastication habits affecting postprandial glycemic level in diabetic mellitus patients. So introduction, India is frequently being referred to as the diabetes capital of the world. Diabetes mellitus is widely prevalent in our country, and its incidence is increasing worldwide at an alarming population. India currently faces an uncertain future in relation to the potential burden that diabetes may inflict upon the country. It is predicted that by 2030, diabetes mellitus may affect up to 79.4 million individuals in India. Diabetes is fast gaining the status of a potential epidemic in India, with more than 62 million diabetic individuals currently diagnosed with the disease. According to Wild et al., the prevalence of diabetes is predicted to double globally from 171 million in 2000 to about 366 million in 2030, with a maximum increase in India. So for this reason, it is very important to have a strong primary prevention, and for that reason, we have used a very easy technique, which is dental occlusion and mastication frequency, which can be basically used by a primary care doctor as well as a primary dentist. So the aim of my study is to study the effect of dental occlusion on mastication habits and postprandial glycemia in individuals with diabetes. The objectives of my study are to study the effect of occlusion defects according to Engel's classification on mastication frequency and its correlation with postprandial blood sugars in type 2 diabetic mellitus patients, to compare the same between dysglycemic cases with age and sex match controls, and to study the effect of dental occlusion on glycemia irrespective of the mastication frequency. So just before I move on, I would like to just highlight what this Engel's classification of malocclusion is, because many of us will not be aware, because this is mainly a dental topic. So Engel's classification, we'll just go directly into the diagram. This is the normal occlusion. It is mainly the first molars of the maxillary and the mandible have to meet together. So this is a normal occlusion. Class 1 malocclusion is also a normal occlusion only. It is considered to be a normal occlusion, class 1. Going into class 2, we see that the maxillary are falling anterior to the mandible. And class 3 malocclusion is a more severe form, where the mandible is protruded more in the front than the maxillary. This is the maxillary cusp and this is the mandible. Mainly, it is how the first molars come and occlude together. This is again just showing how a class 3 malocclusion looks. This is the mandibular teeth which are protruding in the front. So my study method and design, participants included in this study have been first made to undergo a dental examination by a staff member who is Dr. Seena Denny. She's of our sister institute, Manipal College of Dental Sciences in Mangalore. The dental occlusion of the patients have been reported, and accordingly the results obtained, the study participants have been placed into two groups. My two groups mainly are group 1 are the diabetic individuals, which include the pre-diabetic individuals as well, and group 2 are my normoglycemic individuals. Participants' complete history with vitals and basic examination has been done. At this stage, even a baseline GFBS value has been taken, and depending upon the history and examination along with GFBS values, patient will be either placed in the dysglycemic group or the normoglycemic group. Group 1 is the dysglycemic group, and group 2 are the normoglycemic group. Participants on the same day will eat 50 grams of roasted non-salted groundnuts at their own regular mastication frequency, and a GRBS value will be recorded 2 hours after the last bite. So it's mainly like a postprandial sugar. And this is on day 1, where they will eat at their own mastication frequency. The second day is when I will intervene and I will tell them to chew at a frequency of 40, which has been decided according to the parent articles, which says that this is the adequate mastication frequency an individual should have. Study setting, it is done in the outpatient as well as the inpatient departments of hospitals attached to KMC Mangalore as well as Manipal College of Dental Sciences. It is a longitudinal study. The study participants, individuals willing to be a part of the study in the OPD and inpatient wards, have been included. A study duration is from August 2019 to July 2021. Sampling method is a convenient sampling. Sampling size is 160, and the data will be collected and analyzed using a SSPS 25 method. So the inclusion criteria is what I just explained now. Group 1 are the diagnosed cases of diabetes. Group 2 are the normoglycemic individuals with a GRBS less than 100. So group 1 includes the pre-diabetes as well as the diabetic individuals who are aged more than 18 years. Type 2 diabetic mellitus whose treatment regimen has not been modified between day 1 and day 2. So if they're on insulin, we have not modified their dosing between the 2 days. Exclusion criteria is those who have had an extraction of either the first, second, or the third molars, or even the central incisors. Those who have had any orthodontic treatment, for example, braces in the past, have been excluded, and any modification of treatment regimen between day 1 and day 2 have been excluded. And all acute illness cases have all been excluded. Going into my demographics, the age, this is the group 1, which are the diabetic individuals, and group 2, which are the non-diabetic individuals. Her mean has around 48 years of age. In group 2, which are the non-diabetics, we have taken a mean group of 41 with a standard deviation of 15 and 17 respectively. Gender-wise distribution, males are equal to females in both the groups. As you can see here, it is we have 40 males and 41 females in group 1, and in group 2, 40 males and 39 females. Going on to the results per se, descriptive statistics of the PPBS at baseline at 40 for the dental occlusions. Here what you can see is this is the dental occlusion 1, which is the normal dental occlusion. This is the class 2 dental occlusion, and this is the class 3 dental occlusion. You can see as the dental occlusion worsens for the patient, the PPBS as well as the FPS ranges just keep increasing. You can see in dental occlusion 1, the PPBS is 132 with a FPS of 128. As this worsens, the postprandial sugars as well as the baseline FPS keep on increasing. These are scatter diagrams using a Spearman's correlation coefficient. A positive correlation was observed between the variables, and this only shows that as the occlusion increases, the PPBS also increases, and the same goes for the FPS also. This is the next correlation, that is dental occlusion with the mastication frequency, which says that as the dental occlusion worsens, that is as you go into class 3 occlusion, the mastication frequency automatically decreases, but it's a very linear decrease. Going into the comparison of mastication frequency on the basis of groups, what we can see here is that we have taken a class interval for the mastication frequency being less than 20, 21 to 30, and more than 30. This is the mastication frequency the patients had on the first day. So we have seen a very striking difference that among the group 2, that is the normoglycemic individuals, they are having a better mastication frequency. That is 35 individuals were more than 30 mastication frequency, and only 16 were found to be more than 30 in the diabetic group. In the same, we see that as the occlusion is decreasing, like as the frequency is decreasing, we are seeing that they are more going into the more going into the diabetic group. So what I'm trying to say here is that the ones who are having a lower mastication frequency we are actually encountering that they are more of the diabetic individuals than the non-diabetic ones. Comparison of PPBS at baseline and then the PPBS at 40. This is what the topic per se is, which says that as you can see here, PPBS, this is their own mastication frequency, 20, 21 to 30, 31 to 40. So when they're less than 20, we saw that they have a mean PPBS of 195, and 21 to 30 was 156, 31 to 40 was 124. What we can see is that as the mastication frequency is increasing, the PPBS mean values are also decreasing. Then when we tell them to chew at a rate of 40, we can see a significant decline. From 195, the sugars have come to 189. From 156, the sugars have come to 150, 124 to 117, and 109 to 102. A mean of 148, which is a significant drop to 142 when we told them to chew at 40. The discussion, as the dental occlusion increases, the baseline PPBS and FPS values also increase. As the dental occlusion increases, the mastication frequency reduces. Among the dysglycemics, more have a lower mastication frequency than the normoglycemics, and normoglycemics have a better mastication frequency, and a significant drop is seen in the PPBS when persons are asked to masticate at a frequency of 40 among both normoglycemic as well as dysglycemic. The only thing is that population of dental occlusion 3 in my study was very limited. Only 10 of dental occlusion 3 were identified. And the analysis of a PPBS drop has not been done in the different groups. That is, we have not been able to analyze if the drop is more significant in the diabetic or if the drop is more significant among the non-diabetics. And again, diabetics and pre-diabetics have not been differentiated into any group. They have been all classified as group 1 only. These are my references. The message for my presentation is that too slow for your sugars to be low. Thank you.
Thank you, Dr. Golani. This was a very well conducted study, and I think a very simple message which you are trying to give is that if one can increase the mastication frequency, one can chew the food properly, one could reduce postprandial excursions. And there are some earlier studies also on that, and maybe how it acts is not something which we know, but maybe the early phase insulin secretion enhances, and that is how the post-meal glucose comes down. But in any case, it's a very simple and easy message which we can give while we are counseling the patients for diet. I think our dietitians or nutritionists or even the physicians should tell the patient to chew food properly. So that's a very well taken message. Thank you, Dr. Golani.
Thank you so much, sir. Sincerely, thank you.
So our next presenter is Dr. Prashasti Patel. Is she here?
Yes, I am.
Yeah. So she's from Vadodara, and she is going to present on obesity and diabetes are risk factors for severe COVID-19. Dr. Prashasti Patel.
I'll be sharing my screen now. Is it visible?
Yes, sure. Go ahead, please.
Good evening, everyone present here. I am Prashasti Patel, and I'm from Vadodara. So the COVID pandemic hit the world in the later half of 2019, and since then the world has had catastrophic changes. While everyone had a big hit, let's say business or financially or physically, the medical world still kept revolutionizing, and all the researchers were on their toes to bring about something that could help the world treat COVID-19 and reduce the mortality. One such effort was made by me and a few of my seniors at the Parul Institute of Medical Sciences and Research. So today I will be presenting an article on obesity and diabetes as risk factors for severe COVID-19 infection. Obesity has caused massive concerns due to its high prevalence in patients with severe COVID-19 disease. Obesity or ectopic fat deposition may be a unifying risk factor as it reduces the protective cardiorespiratory reserve, as well as it also potentiates the immune dysregulation, which partly plays a role in progression to critical illness and organ failure. Diabetes alone is also one of the comorbid conditions that has shown to influence the severity of COVID-19 disease, along with affecting the prognosis of such patients. Coexistence of diabetes and obesity can cause an even higher risk of severe outcomes due to immune dysfunction. Obesity and excessive fat deposition leads to impaired insulin resistance and reduced beta cell functions in diabetes or those at high risks of developing it. This in turn reduces the ability to produce an appropriate metabolic activity in response to an immunological challenge, leading to an increased amount of insulin in diabetic patients during severe illness. Obesity is said to enhance the thrombosis, which points towards the increased cases of prothrombotic disseminated intravascular coagulation and venous thromboembolism that is very frequently observed in all COVID patients. Obese patients are more difficult to image, ventilate, nurse, and rehabilitate as well. Association between obesity and basal inflammatory status characterized by higher circulatory IL-6 and C-reactive protein levels has also been established. Poor nutritional status and hyperglycemia might aggravate the situation in obese individuals. Emphasizing on the host defense, obesity might impair adaptive immune response to the virus. Obesity individually has deleterious effects on lung function, which leads to reduced forced expiratory volume and forced vital capacity. Taking into consideration the above reasons, obesity might have detrimental effects on prognosis of COVID-19 infected patients. The aim of our study was to understand the existence of obesity as a risk factor, to evaluate the extent of the effects of obesity, to acknowledge the effects of diabetes on the severity of the disease condition, and to recognize obesity and diabetes as individual as well as associated risk factors in COVID-19 infected patients. The methodology of our study, it was a retrospective study performed on 260 adult patients hospitalized at Parul Sevashram Hospital for COVID-19. The data was analyzed and used to estimate the risk of severe pneumonia and the requirement of in-hospital oxygen therapy associated with obesity and diabetes mellitus. The parameters taken into account for the analysis are body mass index, glycosylated hemoglobin, the maximum oxygen requirement, and the duration of requirement of oxygen to maintain an oxygen saturation above 95%. While the BMI and HbA1c were used to detect obesity and diabetes, the requirement, the duration, and the amount of oxygen therapy were parameters for establishing the severity of COVID-19 infection. We also studied the duration of hospital stay and the outcome in context with obesity and diabetes. On meticulous analysis of the data and adjustments of the criteria like age, gender, and comorbidities, obesity was significantly associated with higher odds of severe pneumonia and oxygen therapy. Higher oxygen requirements of severe pneumonia due to obesity was observed in men, older adults, and those with diabetes. Overweight increased the odds of requiring in-hospital oxygen therapy, and obesity increased the prevalence. A linear dose-response curve between BMI and severe outcomes was observed in all patients, whereas a U-shaped curve in diabetics. We identified 260 patients, 40 cases with documented uncontrolled diabetes, and 12 cases of mild, 28 cases of moderate, and 16 cases with severe obesity. We identified 5 patients with diabetic ketoacidosis and 8 patients with microalbuminuria. 208 patients, or 80% of those, were male with a median age of 45 years. More than 2/3 of the patients were reported from urban areas. 78% of patients had mild, 16% had moderate, and 6% had severe COVID-19. Of the 260 patients with information on glycemic control, 61 of them had diabetes mellitus, and of those, 40 had uncontrolled diabetes mellitus with a mean HbA1c of 8.2. Before admission, 3 patients had new onset diabetes mellitus. Of the 40 patients with diabetes mellitus, 5 had diabetic ketoacidosis at the time of presentation. Out of the 260 patients with COVID-19 severity information, 8 patients had critical COVID-19 requiring mechanical ventilation or non-invasive ventilation, while 11 had severe COVID-19. Out of the 8 on mechanical ventilation, 5 who had diabetes succumbed after mean 8 days of admission. 6 out of the 11 with diabetes with severe disease had 7 additional days of hospitalization. 203 patients had mild COVID-19. In the 40 patients with diabetes, 4 had renal failure on admission, including 2 patients who were on dialysis at the time of admission. The data also revealed that 4 patients had neutropenia and 9 had lymphocytopenia. The findings of this study provide important evidence to support obesity as an independent risk factor for severe outcomes of COVID-19 infections in the early phase of the ongoing pandemic. Along with that, obesity in diabetic patients showed poor prognosis when talking about COVID-19 infection, thus suggesting it as an associated risk factor with poor glycemic control in the study subjects. The discussion. Our study has revealed that obesity is an independent risk factor for COVID-19. This is observed more in older individuals, as with age, the muscle mass reduces and the body fat increases. Increased body fat deposition in the body leads to immune dysregulation as well as reduced metabolic response to an immunological challenge. Further, diabetic individuals who contracted COVID had a poor prognosis. This, as discussed above, is due to multiple reasons like impaired insulin resistance, poor glycemic control, and an increased expression of ACE2 inhibitor enzymes, which are the probable sites for virus attachment in the body, thus leading to increased viral load in the diabetic individuals. In diabetic conditions, the circulatory function of the body are lower compared to healthy individuals, and a prothrombotic state in COVID worsens the condition. On a concluding note, obesity and diabetes are observed as individual as well as associated risk factors for a more severe COVID-19 infection. Thank you.
Thank you, Dr. Patel. It was an important study, and you have presented the conclusions, but we did not get any data. You showed the conclusions. You showed that obesity was associated with severity and worse prognosis, and so was diabetes. But we did not get. You did not present. I'm sure you have the data, but you did not present the absolute numbers and the percentages and the tables. So that was a little. We would have liked that to be seen, because you took a lot of your patients had severe COVID-19. This was important. A significant proportion of your patients had severe COVID-19. So this was an important study. And you said you also studied the duration of oxygen therapy, as well as the probably the rate of the amount of oxygen patient received. So to that extent, it was an important study. I think we would be looking forward to complete data about this study.
Sure.
Thank you.
Yeah.
So our next speaker is Dr. Rajamohan Sitaraman from Mumbai, and he is going to present his study on real-world drug utilization study in patients with diabetic nephropathy in a government-run tertiary care hospital in India. So Dr. Sitaraman, please.
Yes, sir. I'm sharing my screen. A very good evening to everyone here. Thank you for providing me with an opportunity to present in such a prestigious conference. So today I'll be presenting an oral paper on a real-world drug utilization study in patients of diabetic nephropathy in a government-run tertiary care hospital in India. So the prevalence of diabetes mellitus in India is about 8.9%.
You must have got a notification to unmute.
Yeah, I was unmuted. So they are used to prepare guidelines such as these. So I can't move this 1 second. I'm not able to move my slides. I'll just stop share and start it again.
No, just
sorry for the. So they are used to prepare guidelines such as these. However, in government-run hospitals, various factors can impact the prescription pattern, and hence they may or may not be able to incorporate the recommendations of these standard guidelines. And hence this study was conducted to study the drug utilization pattern in diabetic nephropathy patients in a tertiary care hospital. Our secondary objective was analysis of ADRs encountered by the patient. Our endpoints were prescription pattern analysis, WHO code prescribing dispensing patient care indicators, and ADR analysis. So a cross-sectional observational study was conducted in the nephrology OPD of a tertiary care hospital in Mumbai from December 2019 to May 2021. So we included stage 1 to stage 4 diabetic nephropathy patients, and we excluded patients who were not willing to participate in stage 5 diabetic nephropathy patients. The classification was done based on Joint Committee on Diabetic Nephropathy classification, which is mentioned here. With this formula, we calculated a minimum sample size of 60, which was required to carry out the study. And our data sources included interview with the patients and prescription of the patients, from which the data was entered into our case record form. And we analyzed the following parameters: demographic and clinical history baseline parameters, details of drugs prescribed, average number of drugs per encounters, percentage of drugs prescribed by generic name, percentage of drugs prescribed in the national essential drugs list, percentage of drugs which were actually supplied by the hospital, percentage of patients having adequate knowledge about drug dosage and regime, prevalence of adverse drug reactions in the last 12 months, ADR analysis for causality, severity, and outcome. So descriptive statistics were expressed in percentage, and we carried out the following tests: Shapiro-Wilk test, one-way ANOVA, Kruskal-Wallis test, and Pearson's chi-square test. p-value less than 0.05 was considered to be significant, and the data was analyzed on SPSS version 25. So coming to results and discussion. So we enrolled a total of 282 patients, from where the most commonest age distribution was 60 to 70 years and 70 to 80 years. The gender distribution was found to be similar for males and females. Then this is a table showing distribution based on type of diabetes and grade of nephropathy. So if you can see, we enrolled a total of 21 type 1 diabetes patients, 253 type 2 diabetes patients. Stage 2 nephropathy was the most prevalent, followed by stage 3, followed by stage 1, and followed by stage 4, which was the least. Now coming to baseline investigation. So there was a significant difference in baseline investigations for systolic blood pressure, diastolic blood pressure, HbA1c, BUN, serum creatinine, urinary albumin, and GFR. It was mostly found to be highest in stage 4, except GFR, which was found to be lowest in stage 4, and systolic blood pressure, which was found to be the highest in stage 3. Then coming to prescription pattern analysis. So the following were prescribed: anti-diabetics, anti-hypertensives, antimicrobials, others including hypolipidemic drugs, anti-anginals, supplements of calcium, vitamin D, and vitamin B complex. So we just did a subgroup analysis of our type 1 diabetes patients. So insulins were the most commonly prescribed, followed by statins, followed by loop diuretics. There are certain drugs which we want to bring into discussion. So in type 1, insulins were the anti-diabetics which were prescribed. In antihypertensives, CCBs and loop diuretics, they were preferred over ACE inhibitors and ARBs. Now, these results are similar to previous Indian studies. However, it was in contrast to the studies which are conducted in Western countries, or the AHA or JNC guidelines, which recommend ACE inhibitors or ARB as first choice drug. ACE inhibitors and ARBs were probably not preferred because of the possibility to cause more harm than benefit at a lower GFR. Now coming to our type 2 diabetes with nephropathy. So here insulins were most commonly prescribed, followed by CCBs, followed by calcium supplements and statins. Here again, we want to discuss some specific drugs. So insulins remain the mainstay of treatment for all stages, and its evidence probably comes from the UKPDS study. Now, if you look at metformin, so metformin was prescribed in all stages, even in stage 3, stage 4, despite the risk of lactic acidosis. And there were no reports. We did ADR analysis and there were no reports of the same. It is permitted as per ADA 2021 and as per KIDGO guidelines, but it is not in the first line as per RSSBI ESI guidelines. GLP-1 analogs, they were prescribed across all 4 stages, and its evidence probably comes from the renal outcome trials such as Carmelina. SGLT2, despite being recommended as the first line drug, and demonstration of positive results in the renal outcome trials was not prescribed to such an extent. It was probably because our patients were from a poor socioeconomic background and they maintained a very poor hygiene overall, and hence risk of infections was very high in them. Here again, CCBs and loop diuretics were preferred over ACE inhibitors, ARBs, for the same reason as mentioned in the previous slide. Here, alpha-2 agonist clonidine was preferred for the management of resistant hypertension over spironolactone, despite the results of Pathway 2 trial, and despite guidelines also recommending spironolactone. Now coming to WHO core indicators. So average number of drugs per encounter. So this is done to assess the degree of polypharmacy, which ensures affordability, compliance, and reduction of drug interactions. So the ideal value set by WHO is 1.6 to 1.8. Our number was 6.47, which was higher than a previous Indian, which was lower than a previous Indian study, which was 7.4. The highest was seen in type 2 stage 4 and the lowest was seen in type 1 stage 1. And there was a significant difference between our subgroups. In such a complex scenario such as diabetic nephropathy, FDCs must be considered once the doses have been stabilized. Then coming to percentage of drugs prescribed by generic name. So it is done to measure the tendency to prescribe a generic name to ensure affordability and compliance. Ideal value set by WHO is 100%, which is difficult to achieve. Our number was 37.70%, which is higher than a previous Indian study where it was 12%. Highest was seen in type 2 stage 2 and the lowest was seen in type 1 stage 1. And there was no significant difference between groups. Still, we feel that there is a requirement of higher generic prescribing despite being higher than a previous Indian study. Then coming to percentage of drugs that were prescribed from the National Essential Drug List. So this is done to measure degrees to which practices conform to national drug policy to ensure affordability and availability. Ideal value again here is 100%. Our number was 59.07%, which was higher than a previous Indian study of 53%. The highest was seen in type 1 stage 3 and lowest was seen in type 2 stage 2. And there was a significant difference between our subgroups. Then coming to percentage of drugs prescribed that were actually supplied in the hospital. So it is done to measure availability of key drugs which are recommended for the treatment of common health problems. They ensure affordability and availability of drugs. Our number was 34.03%. It was highest in type 1 stage 3 and it was lowest in type 1 stage 1. And there was no significant difference between our subgroups. Then coming to percentage of patients having adequate knowledge about drug dosage and regime, it is done to measure the effectiveness of information given to patients on the dosage schedule of drugs they receive. It ensures a higher compliance and lower ADR. Our number was 53.59%. Highest was seen in type 2 stage 4 and lowest was seen in type 1 stage 1. And there was no significant difference between the group. And for these two, that is a percentage of drugs that were actually supplied and having knowledge and about drug dosage and regime. There are no previous studies done on this. Ours is the first study which has evaluated this in diabetic nephropathy patients. Then coming to ADR analysis. So the following ADR, the most common ADRs that were observed were hypoglycemia, followed by lipodystrophy, followed by postural hypotension. Total 86 ADRs were observed. Now coming to ADR analysis. So these 86 ADRs were seen in about 74 patients. They were most commonly seen in stage 2 nephropathy patients, followed by stage 3, then followed by stage 1. Causality for most of these ADRs were probable, means that more than 2 drugs were suspected for causing these ADRs. Outcome was recovered for most of these cases. The severity as per TCA scale was grade 1 for most of these ADRs. Hence, they were easily treatable. And we also carried out modified Schumacher-Thornton preventability scale. And we found that about 32% ADRs were easily preventable also. So I want to conclude by saying that the prescription patterns, they differ from standard guidelines of ADA, KIDGO, RSSDI, AHA, JNC. Insulins still remain the mainstay of treatment for all stages of diabetic nephropathy, be it stage 1 diabetes or be it type 1 diabetes or type 2 diabetes. The use of SGLT2 inhibitors, ACE inhibitors, ARBs are very limited in government hospitals. We feel that a hospital drugs and therapeutics committee must be established in government hospitals. This is to translate our amazing discussions which we have in conferences like these and in peer-reviewed journals to our grassroots of government hospitals. And they can also ensure more generic prescribing, NLEM prescribing, and increased drug availability. And our ADRs were preventable and most of them were also treatable. So these are our references. Thank you.
Thank you, Dr. Sitaraman. It was a useful study. You presented very well. And this is the type of data which we need in this country, our own data from our own hospitals. And this is useful. Like 37% of patients had hypoglycemia. So which means we need to be more careful and we need to address this issue. 7 patients in stage 4 were given metformin. So which is again not expected maybe, but yes, maybe. So there could be some reasons for that. But what I was intrigued by the observation that SGLT2 inhibitors were used very sparingly, hardly any. And while GLP-1 were used at all stages of CKD. So what do you attribute it to?
Sir, actually, liraglutide is actually very frequently prescribed, and I think it is also available in the formulary. It is available in the formulary, which kind of makes it a reason to be prescribed.
No, mostly non-availability of the drug in the hospital, government centers. That is the most important.
Yes, sir. Yes. Since the risk of Fournier's gangrene came up with SGLT2 inhibitors in government hospitals, actually they are very scared to prescribe SGLT2 because we kind of assume that our patients have a very poor hygiene.
What about ARB and ACE?
Sir, actually, what happens is that at a lower GFR, they can cause more harm than benefit because of the fact that they can affect the glomerular perfusion, which is required to be maintained. So because of inhibiting angiotensin 2, they can affect the perfusion, and they can also cause hyperkalemia. That's why there is a fear of prescribing ACE inhibitors, ARBs in patients of a lower GFR.
But you are a nephrologist. If it is there, you could have studied serum creatinine and the potassium levels. Sir, once you start ARB, ACE, you should have studied that. But your methodology of all the papers, your methodology is very good. Approach is very good.
Thank you, sir.
Thank you, sir. You can proceed.
Thank you. Thank you, Doctor. Our last speaker in this session is Dr. Sayali Deshpande Joshi. She's from Pune and she'll be presenting her study on preliminary analysis of the relationship between maternal insulin resistance and neonatal birth weight across populations. A very interesting topic. Welcome, Dr. Joshi.
Thank you, sir. Are my slides visible?
Sure, please go ahead.
Yeah, I'll move straight forward with my presentation. To give a background, maternal nutrition and metabolism are major determinants of fetal growth. Pregnancy is characterized by adaptations in weight, glucose, and in lipid metabolism to meet the increasing nutritional demands of the mother, the placenta, and the fetus. This is maintained by increasing the hepatic glucose production and increasing insulin resistance with increasing gestation. The association between maternal insulin resistance and fetal growth, however, is not explored across populations. Therefore, we examined the association between maternal insulin resistance and birth weight in over 8,000 pregnancies from 14 studies in different countries and in multiple ethnic groups. We searched literature using PubMed and Google Scholar. We also had access to our departmental pregnancy studies and used data from those. Data was also shared by our collaborators on pregnancy studies. The keywords used for literature search was pregnancy insulin resistance, HOMA-IR, glucose, insulin, BMI, and birth weight. The inclusion criteria was availability of data on maternal age, BMI, fasting glucose, insulin concentrations, HOMA-IR, and birth weight at 28 weeks of gestation. Studies were excluded if they reported on special situations such as after a bariatric surgery or macrosomia-based studies. Group level data, that is mean or median values, were extracted and used for the analysis. We performed a multivariate linear regression to test the association between maternal insulin resistance and neonatal birth weight. Literature search fetched us 9 studies consisting of 18 subgroups such as a control group or an intervention group or multiple ethnic groups. Out of these 9 studies, 5 studies met inclusion criteria and had 10 population groups. We used data from 4 departmental studies having 5 population groups. In addition, we also had access to 5 studies which were shared by our collaborators, and those had 11 population groups. Thus, in all, we had 14 studies, had 26 population groups coming from more than 14 countries, having pregnancies over more than 8,000. Group level data was extracted to investigate the association between maternal insulin resistance and neonatal birth weight. We observed that there was a wide range in maternal characters as well as the neonatal birth weight. For example, maternal age ranged between 21 to 32 years, BMI between 20 to 36 kg per meter square, fasting glucose between 71 to 96, HOMA-IR between 0.3 to 3.4, and importantly, neonatal birth weight from 2,600 to 3,700 grams. Next, we examined the association between maternal characters at 28 weeks gestation with neonatal birth weight using a univariate linear regression. We observed that maternal age, maternal BMI, fasting glucose, insulin, as well as HOMA-IR were positively associated with neonatal birth weight after adjusting for gestational age. This implies that mothers who were older had larger BMI, had higher concentrations for glucose and insulin, and importantly, those who were insulin resistant at 28 weeks had heavier babies. Next, we performed a multivariate linear regression adjusting for confounders. In model 1, we included glucose and insulin as independent factors and made adjustment for maternal BMI, age, and gestational age. Glucose and insulin in this model did not show any significant association with birth weight. However, in model 2, we included HOMA-IR. And we saw a positive association for HOMA-IR with birth weight after adjusting for maternal BMI, age, and gestational age. 1 SD increase in HOMA-IR was associated with 0.4 SD increase in offspring birth weight. Thus, mothers having higher insulin resistance during mid-pregnancy had heavier babies. An important observation here was that pregnancies from Indian subcontinent were at the lower end of the distribution of HOMA-IR and birth weight. These mothers also had lowest body mass indices. The strength of our analysis is that it includes data from over 8,000 pregnancies coming from more than 15 countries and multiple ethnic groups. Also, there was a wide variation in exposure variables as well as that in outcome variables, which offers a greater statistical power. The limitation, however, is that this is a group level analysis and we were not able to make adjustment for sex, sample size, study design, and assay methodology. This is a preliminary exploratory analysis, and we do plan an individual level formal analysis in near future. To summarize, this preliminary exploratory analysis brought about the association between maternal insulin resistance and birth weight independent of confounders. Importantly, Indian subcontinent pregnancies were at the lowest end of BMI, HOMA-IR, and birth weight distribution. This is a novel explanation for low birth weight babies in young and thin Indian mothers, and formal analysis will follow soon. These are a few references which I have used. My acknowledgements to the collaborators and authors for sharing their valuable data, which has made this analysis possible, to the staff diabetes unit for their support, to the study participants. My acknowledgements are also due to Professor C.S. Yagnik, who has driven this research and guided me immensely. Thank you, Diabetes India Congress, for this opportunity to share our results on this prestigious stage. Thank you, delegates, chairperson, and attendees for your patient listening. Thank you.